Dear colleagues, dear friends, it's a great pleasure to welcome you to this new EHAT podcast. This one will concentrate on von Willebrand disease and more specifically pregnancy and the delivery. And as you know, this podcast is complementary to the EHAT learning module that you have recently discovered. To do this, I have the great pleasure to welcome today Dr. Michel Lavigne. So Michel, thank you. Thank you for joining us today. So maybe you could introduce yourself.
So I work as a consultant hematologist in the National Coagulation Centre in St James's Hospital in Dublin and a researcher in the Irish Centre for Vascular Biology in the RCSI. And I'm always delighted to have the opportunity to try and talk and educate and advocate for women and girls with bleeding disorders and for those with von Willebrand disease. So thank you to EHAD for supporting this podcast and the education module that connects us with it.
Thank you, Michel. I was in Dublin a few years ago, and I have to say this is a great place, not only for the clinical follow-up of the patient, but also in terms of research. So maybe tell us, so you have a major interest in von Willebrand disease, so and especially in women. So why is it like that? Where did you get your interest from?
Well, I think like many others, I started off in hemostasis with a real interest in hemophilia. And really, it was just talking to the patients and meeting more and more people with von Willebrand's and hearing their stories and capturing the bleeding histories that people had experienced. It was really quite striking and quite surprising. Even the bleeding people continued to experience after they were diagnosed. So, at that time, there was a lot of interest about low von Willebrand levels and whether that was actually a bleeding disorder or not. And we set up the LOVIC study to look at that. And what came through really strongly from the bleeding scores that we did on all the participants was the degree of heavy menstrual bleeding and postpartum hemorrhage that women had experienced prior to and after diagnosis. So I really felt this was an area that warranted a lot more attention and advocacy and improvements than where we were standing at that time.
Thank you. Well, it's clear that many patients with von Willebrand disease or low von Willebrand factor are women and girls, and clearly they have to cope with multiple hemostatic challenges. Clearly, menstruation is a major issue, but also pregnancy and the delivery. And this is the topic that he will discuss and cover today. So maybe in terms of pregnancy, so what could you tell us about how von Willebrand factor and factor VIII behave during pregnancy?
Well, in normal, healthy individuals who are pregnant, you'll have an increase in your von Willebrand and your factor VIII levels accompanying your von Willebrand factor rise. And that'll start actually quite early in pregnancy. So even in the first trimester, you'll see an increase occurring. And that brings your baseline VWF levels up from, we know the normal range is between 50 and 150. The average VWF level, and we're talking about VWF antigen here at delivery, would be about 250 in healthy individuals. So you get at least a 2 to 3-fold increase in your levels. And of course, it's different if you have von Willebrand disease, because depending on the type and the subtype, you may not be able to synthesize or secrete your VWF normally. In those cases, your levels may not increase. But for many patients with type 1 or low VWF levels, we'll see that their von Willebrand levels will start to increase very early, even in the first trimester, and may go up to what is within the normal range at the time of delivery. But remember, this is the normal range that we use in every patient, irrespective if you're 5, 50, 95, pregnant or non-pregnant. So it may be normal, but it's not actually normal for pregnancy.
In my view, it's important to make sure that we have at least a good evaluation before pregnancy. Because sometimes this lady might be diagnosed during pregnancy, but in your view too, you think that it's important to make sure that we have a good assessment of the von Willebrand factor severity and type before pregnancy.
Yeah, I think it's almost impossible to diagnose von Willebrand disease in pregnancy because the majority of people with von Willebrand disease will have type 1 or low VWF. So of course, if you have, a type 2 patient, you'll be able to see that discrepancy persist throughout pregnancy and they'll be diagnosed then. Hopefully a type 3 patient will be diagnosed long before then. But for the majority of people that are referred to our centre in pregnancy, it's because of a family history of von Willebrand disease. And it can be very difficult then to determine if their levels are truly normal or have just increased in pregnancy. And in that situation, it really comes down to the bleeding phenotype and their history, and if they've had challenges before, how they've responded to it in terms of how you make the decision regarding delivery planning.
Yeah, and so let's say we have a patient, she has von Willebrand disease and then she's pregnant. So how will you follow these patients during their pregnancy? And will there be any impact on the severity or the type of Willebrand disease on the management during pregnancy? I mean, the follow-up.
Absolutely. So I think it differs from center to center. The practice in our center will be we will encourage all women to contact us as soon as they're pregnant. So even before or just as they book with their general practitioner, they'll probably let us know that they have become pregnant, and we'll link them in for follow-up and assessment during their pregnancy. And we'll try and have a combined approach with an obstetrics unit. So even if that's not co-located with our site, we will link in with their obstetrician and have correspondence forward and back, and the patient is at the center of all those discussions and involved in all those discussions. I think it's really critical that you perform levels on patients prior to any procedure. If there's any antenatal procedures that are required, or if there's any bleeding complications of concern, or at 28 weeks. So the guidelines will stay in the third trimester. So the third trimester is a long time, and babies often arrive earlier than their due date. So I would advise people that, once a woman is at 28 weeks, you really should be doing your levels at that point, so you can plan early in the third trimester the delivery plan with that patient and with her obstetrics, pediatrics, anesthetics team. In terms of how the type of von Willebrand disease influences decision making, for many people with type 1 and low von Willebrand factor levels, their levels will increase in pregnancy, and they may increase to over 100 IU per deciliter or 1 IU per mil. So typically those patients may not need additional hemostatic support in the form of clotting factor replacement therapy or DDAVP. The guidelines would recommend that everyone gets tranexamic acid postpartum, so that's always something just to remember. But for patients with type 2 von Willebrand disease, they have a dysfunctional protein, and they're going to make more of it, but it's going to retain that dysfunction throughout pregnancy. So they should be flagged early as somebody who's going to require hemostatic support in the form of clotting factor replacement therapy at delivery. And I think it's important to bring those women in early in their pregnancy to have that discussion with them, because they may not be suitable to deliver in their local obstetric hospital if it's a very small hospital and without access to hemostatic testing. Now, that testing may not necessarily need to be on site, but it has to be able to get to a lab and get a result in a timely fashion. It can't be just batched and sent next week, not for delivery.
So clearly, week 28 is important. Blood assessment is certainly critical, so you need to reassess factor VIII, von Willebrand factor, antigen, and activity at that time. This is very,
Absolutely.
and maybe also, the food blood count, the platelet in case of 2B and things like that. So week 28. And then, as you nicely explained in your presentation, you need to agree on the management plan anticipating the delivery. So what should be part of this? We will discuss later on a little bit how we manage the delivery and so on, but what should be well explained or well agreed on in this management plan?
What we will normally do is bring the patient to us and have a discussion with them about their values and preferences about their delivery. And normally what I would find is that women are happy to proceed with the plan that's safest for them and the baby, and they may have an ideal scenario about what type of delivery they would want to have, but they want to have a safe delivery first and foremost. What's important is that the presence of a bleeding disorder shouldn't determine whether you need a section or a vaginal delivery. That's an obstetric indication. So if there's other factors like a breech, that will determine the mode of delivery. But from that conversation, which should happen at the 28-week review, maybe with the plan put in place when the levels are available within the next 1 to 2 weeks, there should be a clearly written plan that's provided to the patient, to their obstetrician, to the anaesthetist, the pediatric teams, the neonatal teams. If there's laboratory monitoring involved, we will also send it to the lab that's local, so that everyone is aware that these samples are coming in and where they're to be processed or to go to if they're to be sent off site. And if there's a hemovigilance officer who's in charge of the clotting factor replacement therapy in that hospital, so that everybody is aware there's a baby coming and a mum that's due to have a delivery, and if they need treatment, that everything is already lined up, rather than trying to act on that on the day that a woman goes into labour. So I think the most important thing is clear written communication that's available to all parties involved in the delivery, and that's agreed with the mum and with the obstetrician in terms of providing the best possible outcome.
Yeah, an important question that will come on the table is certainly the analgesia, the modalities of analgesia. whether neuraxial analgesia will be possible, yes or not. So what would be your recommendation about analgesia, neuraxial analgesia, and the modalities of this?
So I think this is hugely important. I had 3 epidurals, one with each of my deliveries myself. So I'm a big fan, but we have to we
You
have
know
to
what we are talking about.
yeah, I don't like denying women access to good analgesia. It's a really important component of care. When it comes to neuraxial anesthesia, we're wondering, what's the risk of bleeding? And if you do develop a bleed in that area, it's such a critical point that it is, this is a life-changing bleed potentially, and it could end up in paralysis. So the risk of bleeding from an epidural in the general obstetric population is 1 in 168,000, but we don't have any data about what that rate is in women with bleeding disorders. Now, the guidelines would recommend that once your levels are over 50 IU per deciliter, that you don't need additional support for the delivery of an epidural. But there's a concern with von Willebrand disease that you may not correct platelet von Willebrand factor levels, only your plasma VWF levels. So that's one consideration. If you artificially correct those levels through the administration of factor concentrate, you need to be sure that you can maintain those levels throughout the time that that epidural is sited, is in situ, and is removed, and for 6 hours afterwards. And on a practical note, that's often very difficult in a busy obstetric hospital, which may not be co-located. And actually, when you give the treatment at the onset of labor, the timing of the epidural may be significantly later than that, depending on how the labor progresses. So you have to consider the rate of fall off. So for many patients with type 2 von Willebrand disease, they may not be suitable, and type 3 von Willebrand disease, to have neuraxial anesthesia. But practices vary internationally on this, and we looked at this in a recent study, and we allude to it again in the module, and I go through this. But certainly we would be reluctant to have a lady with type 2 VWD unless we could guarantee that there was accuracy and certainty about levels at all times, which is very difficult in an obstetric setting.
You really need to make sure that the multimers, the good multimers are there, and that the functional activity of von Willebrand factor is sufficient, which is not always easy to achieve. I'm thinking about patients with type 2A. These are, in my experience, very difficult patients. If you think about restoring more or less normal multimers, even with intensive replacement therapy, this is quite challenging. Is it also your own experience?
Yeah, definitely. And I think it depends also on what concentrate you have access to, because obviously the multimer composition varies by concentrate significantly. There appears to be more high molecular weight multimers with recombinant von Willebrand factor, but that poses its own challenges in terms of the additional factor VIII that may be required. So these are complex situations. And provision of clotting factor concentrate in obstetric settings is always challenging, so I think we have to be careful that we don't make things more difficult or put a patient at risk. The additional point I didn't mention actually also is about patients with type 2B, that they can have an associated thrombocytopathy. So I think that they would be out for a neuraxial anesthesia, from my perspective anyway. And this is an area that's based on clinical practice rather than evidence.
Yeah, and in terms of, because I'm sure that our colleagues would like to hear from you, what sort of levels should be targeted? If you think about factor VIII, von Willebrand factor, antigen, and activity at time of the delivery, so what levels would be needed?
Yeah, I think this is very controversial and really interesting. And I'm afraid, Cedric, I don't have the correct answer. I know what people do and what we do, but I'm not sure what's correct, because there have been efforts to try and address this in studies. And a major problem with von Willebrand disease in pregnancy is that it's very difficult to recruit. It's very difficult to start these studies and to fund these studies. There are a number of studies they're trying to address these issues as to what is the best target. And I go through the available studies that we have, which are very limited in our module. But the VIP, or the von Willebrand disease in pregnancy study, at last notification only had 9 women recruited to it. They are trying to push for more recruitment again. Of course, COVID has limited this. But traditionally, I think it's funny, we talk about different targets at delivery, because we say you can be over 50 and have an epidural, but then we want people to be over 100 at the time of delivery. But of course, these two things are happening simultaneously. So I think it's somewhat artificial to be talking about epidural separate to the delivery process.
Yeah, sure.
For everyone, they should be at least over 100 IU per deciliter at time of delivery in terms of the VWF activity and their factor VIII levels. And there's a question as to whether we should be raising that target further to greater than 150. And the reason that this is queried is because despite the use of clotting factor replacement therapy to bring people to these levels, or the women who endogenously correct to these levels, we still see elevated rates of postpartum hemorrhage in
Yeah.
women with Willebrand disease above that of the normal population. So that would suggest that we actually aren't targeting our levels high enough. And they certainly remain significantly lower than the normal population, who would have a median level of 250, as we discussed earlier.
Yeah, very important concept. We still have a few minutes. Question about DAVP, because this is also a question that frequently comes on the table. Could we use DAVP, and with what sort of precautions?
Yeah, so DDAP is it's interesting as well, because I think it's very difficult to shift some people's ideas about DDAP and when you can and can't use DDAP. And actually, even since we did this module, there's been another a systematic review of DDAP use in pregnant women with bleeding disorders from the Dutch Symphony Group. So that was just published in JTH in January. And they have updated the previous reviews from majority are from Razan Abdul Qadir's group, looking at DDAVP in pregnancy. And what's coming through from, we have no randomized controlled studies of DDAVP use in pregnancy in women and girls with bleeding disorders. In fact, there used to be a Cochrane library review, and they have abandoned it because they said, no randomized controlled trials were identified on the effectiveness of DDAVP in women with bleeding disorders, and there was no plans to repeat it because they'd already repeated it twice and no new data had come in the meantime. So in 2019, they abandoned that process. So we have only data from case series, individual case studies, and obviously there's all the publication biases that can go with those. And these are patients with women with all different types of bleeding disorders, not just von Willebrand disease. So the most recent systematic review is of 273 pregnancies, and they found at delivery there was 232 deliveries, and that there was two episodes of hyponatremia. Now, one of those is from a paper published in 1986 and one from 2015. The paper in 1986 gave 3 doses of DDAVP 18 hours apart. So I think that's,
That's crazy.
perhaps doesn't reflect current practices. And then there was one episode of hyponatremia with some neurological sequelae, but they didn't explain, or some neurological symptoms, sorry, rather than sequelae, but they didn't go into it further as to the actual sodium level at the time. So I think that the rate of hyponatremia is low. We have to be cognizant of it, and certainly when it's used to prevent PPH, you'd hope that there's better chance at fluid control. I think we have to be cautious in somebody who is having a PPH. I wouldn't be rushing to use DDAVP because it's going to be virtually impossible to fluid restrict that individual in the time afterwards. So that's the use of DDAVP at delivery. But in terms of, it can be used antepartum, so in order to support women through procedures, or if they have, if there's a concern about bleeding, there's always this, it's always brought up about, does it have an oxytocin effect? Will it induce premature delivery? That doesn't appear to come through strongly in the data, but again, it's very limited. And that's systematic review. I think there was 60 times it was used antepartum. There was 2 adverse events. One was that was a fetal intrauterine growth restriction, but the woman also had diabetes. And the other adverse event was that it was given as a test dose at 36 weeks, and the woman went into premature delivery, and they didn't know if it was DDAVP related or she was in the 10% of people who will deliver before 40 weeks. So I think there's probably more concern about DDAVP than there is evidence of adverse impact. It's a useful tool to have, but in my experience, many of the women who fail to respond to DDAVP, or sorry, who fail to increase in pregnancy, may not get a great response to DDAVP either.
Yeah, let's now move to the, the after delivery, or postpartum hemorrhage. A few key messages concisely about this.
So I think we underestimate and underappreciate secondary postpartum hemorrhage, and women with von Willebrand disease are amongst the highest risk group for secondary postpartum hemorrhage. This happens after women go home, so it's often missed. And these are women who have normalized heavy menstrual bleeding all their lives. So we need to advise women what the symptoms and signs are of secondary postpartum hemorrhage. They need to know that if they go to an obstetric hospital for assessment and they don't, they're often sent home because they don't have infection and they don't have retained products, that they still may need treatment for their bleeding disorder. And they need to know how to access that pathway for every centre.
So maybe, to conclude, what sort of key take-home messages would you have for our audience?
So I think the most important thing is you should be talking about pregnancy before a woman is ever pregnant.
Yeah.
So, try and optimize iron levels before a woman is pregnant. Talk to them about what their, options are, because they'll have to come off contraception and their heavy menstrual bleeding may get worse. Let them know that they should link in with you when they're pregnant, and make sure that you have a plan to see them when you know somebody is pregnant early in the third trimester, to get that delivery plan and those levels ready, and make sure that all the questions have answered. If you have a woman who you think is going to need hemostatic monitoring or more intensive support at delivery, I would also make sure we see them early in pregnancy if they're planning, so you can plan the location of their delivery with them. I don't think it's fair to change somebody's delivery location at 28 weeks. They've already established a relationship with their treaters at that point on the obstetric side. And just monitor for bleeding, make sure everyone is aware of how to contact the hematology services if there is bleeding at the time of delivery, and that you have a plan and consider everyone for tranexamic acid in the postpartum period, and that's for 2 weeks.
As you really nicely illustrated in your lecture and today, I think the situation has significantly improved, but still there is a lot to do. And certainly in terms of research and unmet needs, you already addressed some of them, but I think a lot needs to be done in this area to collect and gather more evidence. Certainly, you cover the levels that are needed, the use of DDAVP. Do you see other, priorities in research for the next few years?
Well, I think if we could have better predictors of bleeding in von Willebrand disease, we have a lot of patients who have mildly reduced levels and may have had some bleeding in the past, but it can be very difficult to predict from those group who will bleed with challenges until, unfortunately, they develop more complications. So I think if we had better tools to predict bleeding, it would improve the care of people with von Willebrand disease as a whole. If we can, identify what those target von Willebrand factor levels at delivery, that should be a key priority for the management of pregnant women. And then in the postpartum period, we don't have very practical tools that can help women to monitor their gynecological bleeding, or a sense of what are the best therapeutic options for whenever they get their periods back, and perhaps they may be heavier than they were beforehand. So, that transition back towards hormonal therapies or tranexamic acid, and when they should happen, isn't clearly defined.
Well, thank you. Well, it was a real pleasure to discuss with you. You are really passionate about this, a great expert, plenty of insight, and I hope that our audience had the same pleasure. So thank you again for contributing to this podcast, and I'd like to invite you again to listen to your full lecture presentation on the platform. And I invite all our colleagues to listen to all podcasts, EHAT podcasts, which are increasingly popular, receiving a lot of attention in the community. So thank you for making this possible, Michelle, and I wish you a great day. Bye-bye.